Okay. Yeah. So for the intoxications and withdrawals, one thing that I want to tell you, which is it'll help you with a lot of these questions, is that if you only remember one of these two columns, if you only remember the intoxication, you can in theory figure out what the withdrawal. So let me give you an example. And the best example here would be cocaine intoxication. Just as an example for now. So cocaine, it's a stimulant medication, and because it's a stimulant, it would do all the things which the stimulant medications do. So it will cause tachycardia. Along with tachycardia, it will cause suppression of hunger. It will cause restlessness, and that is majority of what these stimulant medications do as a general class. So when you have a withdrawal, you'll see the opposite effects. So here you'll see hunger because there was a suppression of appetite with stimulants, so you'll see more hunger. Because there is elevated mood in cocaine intoxication, you'll see as a side effect depression. And then because stimulants can affect how you sleep, so they'll keep you awake for much longer. In the setting of cocaine intoxication, you'll have like brief periods of no sleep, so insomnia. But on the other hand, withdrawal will lead to increased sleep, which will be like more sleep for these patients. So that was a rough idea. And yeah, if you can use this, that whatever the intoxication is, the opposite would happen for withdrawal. That will help you with a lot of these questions. Okay, so let's start with alcohol. Now, alcohol is probably the most common drug that patients can consume along with nicotine. And the problem with alcohol, right, is obviously we know that patients will be emotionally, so a patient will have more emotional liability, they'll have slurred speech, ataxia, coma, and blackouts. That is what we all know. Like if we think about someone who's consuming a lot of alcohol, we might think of these side effects. But here is what the USMLE wants you to know, this line, that whenever you do lab studies on someone who has been consuming alcohol for a long period of time, you'll see that the AST is more than 2 times the ALT value. Now, this is important to know because sometimes they won't really give you very specific signs of alcoholism, and instead they might only give you the hepatic values. Now, okay, as a side note, do you guys remember the condition in which you can see very high ALT, somewhere around 1000 or more?
Tylenol overdose?
Could be, but not more than 1000. It can increase ALT, yeah, but not more than 1000.
Acetaminophen overdose.
No. So acetaminophen and Tylenol, I think they're the same. Yeah.
Yeah.
So not acetaminophen. There is one more thing, and this is very specific. That whenever you have an ALT level of more than 1000, that is very specific for hepatitis A. More than 1000 is very specific for hepatitis A. And now, what do you think happens in the chronic phase of hepatitis A? So, what do you guys think?
Not sure.
So, this is an important thing to remember. There is no such thing as a chronic hepatitis A patient. Hep A will always
Oh
be
man,
acute.
yeah.
Yes.
Yeah.
And the antibodies will always be IgM. And then hepatitis A is usually self-limiting, so you like don't really have to treat them with anything. Yeah, so that was a small tangent. Now, what can you do for someone who has been intoxicated with alcohol? You treat them supportively. You don't really need to give them any kind of medications. However, when we later look at the withdrawal of alcohol, we see like multiple different problems that can emerge, and those you need to treat. because they can be life-threatening. Next, we have barbiturates and benzodiazepines. Now, a lot of these symptoms for barbiturates and benzodiazepines, they overlap. They're both CNS depressants and they both act on the GABA receptors. Now, the difference is barbiturates. So, do you guys remember barbiturate? Does it affect the frequency or the sorry, uh, frequency or the intensity? Yes,
Duration.
duration. Yes, sorry, duration. Yeah, barbiturates for duration, and then benzodiazepines for frequency. Yeah, and then remember that barbiturates can cause a much greater CNS depression. That means it's less safe compared to benzodiazepines. Benzodiazepines can also cause CNS depression, but not as much as barbiturates. And then if someone is on a benzodiazepine overdose, you can treat them with flumazenil. Yeah. So if someone is on benzodiazepines, you can treat them with flumazenil. Now, one more thing is, as I said, both of these are depressants. So a lot of the side effects that you see will be depressing side effects. That means they'll have respiratory depression. They might have CNS depression because of which they're at an increased risk for falls. They might sleep a lot. They might have slurred speech. Ataxia is one. So all of these different side effects. Don't worry, when we do questions for all of these medications, I'll tell you like how they present these intoxications and overdoses. Now, the withdrawal from benzodiazepines, right, and from barbiturates, they usually are non-specific. Like you won't really have any specific features. However, this here is important to remember that a withdrawal from barbiturate abuse can cause cardiovascular collapse. This part is important. All the other ones, usually they'll be very non-specific and they won't really give you sorry, the withdrawal from these medications, from benzodiazepines and barbiturates. They'll majorly focus on the intoxication. Next, we have opioids. Now, opioids are an interesting one because we use these for pain modulation and the opioid medications, right? They can also be used as antidiarrheals. So these are two ways you can use them. Now, because these medications are used as antidiarrheal medications, they can decrease GI motility. And then opioids are also depressants. That means they will cause respiratory and CNS depression. They'll cause a decrease in gag reflex. And yeah, one or a couple of interesting things here. Meiosis and the GI motility. These are the most important symptoms that you need to remember for opioid intoxication. Now, one thing which is very important is that the constipation, even when you stop the medication, even when the patient has stopped consuming opioids, they will still maintain the constipation, and this symptom would not change. It says here that they'll have diarrhea, but for a long time after stopping the medication, they'll still maintain the constipation. Yeah. And then the overdose treatment for these patients is naloxone. Now, similarly, so we said meiosis and GI motility were the main symptoms here, and the GI motility it really doesn't change. But then in the withdrawal, you'll see mydriasis. So meiosis is pinpoint pupils, that the pupils are very small, and then in mydriasis, the pupils become very large. However, the most important symptoms right here would be yawning. Sorry, yeah, yawning and then pilorection. These are very specific for opioids. And if you see a patient who is feeling a little like withdrawn, like he has some kind of drug withdrawal, And along with that, he has yawning or piloerection, which is like the cold turkey. You can assume that these patients have a withdrawal from opioids. And then the treatment that we want to give these patients is actually a partial opioid agonist, or usually, yeah, a partial opioid agonist would be the best. And one important thing here, yeah. So if the patient is having so if the patient is on a high, that means the patient is currently intoxicated with opioids. You never want to give these patients a full antagonist because then you can directly precipitate withdrawal effects. And then the withdrawal effects of opioids, they're considered to be the worst along with alcohol, which are the worst withdrawal side effects to have. So whenever someone is intoxicated, you do not give them a full agonist, and instead you can give them a partial agonist, and then from there you can uh, modulate their plan. Next we have inhalants. Now one thing about inhalants, right? For some reason the USMLE will always give you a relatively younger patient for inhalant abuse. Now inhalants, usually it could be any kind of aerosol. Think about kerosene, that can be used as an inhalant. I've heard that glue can be used as inhalant. Petrol can be used as inhalant. All of these different like aerosols can be used as inhalants. Now, the USMLE likes to give you relatively young patients for these, and along with that, you will see redness or scarring around the mouth in these patients, around the nose and the mouth. Now, this is very different compared to opioids, in which you'll only see like nasal septum problems and like nose redness. For inhalants, you might also see perioral or oral erythema. And usually these will also cause euphoria, disorientation. But this part here is the most important, the periorifacial rash. And then the withdrawal side effects, they're pretty non-specific for these patients. Yep. Next, we have the stimulants. Now, stimulants, think about these effects: tachycardia and anxiety. These are very non-specific symptoms, and you'll see them with probably all the stimulants. And these are the most important ones. Now, we have amphetamines, caffeine, cocaine, and nicotine. So, amphetamines. Usually, these patients, right, the way the USMLE will give you a patient, this patient will scratch themselves a lot. They'll have a lot of excoriations on their skin. Along with that, they'll have some missing teeth. And overall, they look very unkempt. That is the type of patient you're looking for when the USMLE is asking about amphetamine abuse. Yeah. So you have yeah. So the skin excoriations, and in addition to skin excoriations, also think about missing teeth and overall unkempt appearance. Now for side effects, this here is very important, that you have tactile hallucinations. However, a lot of these withdrawals might have tactile hallucinations. So alcohol withdrawal can also have tactile hallucinations. Cocaine withdrawal can also have tactile hallucinations. So you have multiple different tactile hallucinations that you can get. And what tactile hallucination means, that it actually feels that there is some kind of bug crawling under their skin, or they feel like there is something on their skin, so they can actually feel it. They're not seeing the hallucination, but instead they're feeling the hallucination. That's what tactile hallucinations mean. Oh yeah. And now, because amphetamine is a stimulant, so then for treatment you can give them something similar to a benzodiazepine to calm them, because these patients usually will be very aggressive. Next, we have caffeine. Now, caffeine usually present in coffee, tea, and a lot of these. Caffeine is actually the most consumed psychoactive substance in the world, and overdose on caffeine it's pretty rare, but it can happen. And usually, it will give you palpitations, insomnia, and one thing that they don't mention here, right, is an impending sense of doom. The patient will actually feel like there is some kind of like threat to their life. They'll just feel like something bad is about to happen, like an impending sense of doom. That is what you can get with caffeine intoxication. And then the withdrawal, usually headaches are the most important withdrawal. However, flu like symptoms can develop, but these are very rare. Yeah. Next, we have cocaine. Now, in cocaine, usually it will be a nasal route of ingestion. That means the patients snort cocaine. And then symptoms would be mydriasis, which is important, and yeah, sudden cardiac death. Now, the reason why these patients have a sudden cardiac death is because whenever you take a stimulant, especially cocaine, you develop tachycardia. And this tachycardia, it's so extensive that the patient's heart just kind of gives up. It's like it's worked too much and now it just stops working. That's how you develop this sudden cardiac death. And then because cocaine is one of those corrosive medications, and because the route of inhalation is nasal, it can perforate the nasal septum, and it can actually perforate both the parts. It can also perforate the cartilaginous part, and it can also perforate the bony part of the nasal septum. And then once it's perforated the nasal septum, the only thing you can do is actually rhinoplasty. There is no other treatment except for rhinoplasty with a surgical reconstruction. Treatment here again, because it's a stimulant, you want to give them something more sedative, and the medication you can give them is benzodiazepines. Finally, nicotine. Nicotine, there's not a lot of side effects of nicotine intoxication. However, the few side effects that we have would be very similar to caffeine intoxication, which is you'll get palpitations, you'll get insomnia, you'll get restlessness. However, the withdrawal, that is where the USMLE will test you. Usually, the question that USMLE asks you about nicotine withdrawal is how best to manage the patient. So, this part. Now, the management for these patients, there are three things you can do. First, you can give them a medication called varenicline. This is a partial nicotine agonist, and this is the best medication that we have, and the most effective medication for patients with nicotine addiction. The second thing you can do is you can give them bupropion, which is an antidepressant, and this has the second best, uh, effect for patients with nicotine addiction. And the third thing you can do is nicotine replacement. Now, nicotine replacement is you can give them any kind of other product which contains nicotine to satisfy those cravings and to prevent withdrawal, but at the same time discouraging smoking. So it could be in the form of patches, could be in the form of gums, could be lozenges, which are small tablets which you can suck on. Now, the idea with giving these patients patches, gums, or lozenges is that you ultimately want to separate them from the habit of smoking, and after that you slowly discontinue the nicotine that they're consuming. So let's say someone starts with five nicotine patches a day. Then over the next month, you want to reduce it to, let's say, two, and then the next month you can reduce it to one patch a day, and then slowly you can reduce the dosage. So that is how these nicotine replacement medications work. Yeah. Now with hallucinogens, all of these medications, they can cause hallucinations, but the USMLE, they'll ask very specific things here, and that is that if you have LSD intoxication, you will always get these flashbacks. Additionally, one more thing that the USMLE can do is they'll give you halos around lights. and that is also a very good buzzword for LSD intoxication. Additionally, yeah, it can also cause perception distortion, it can cause depersonalization or derealization, paranoid psychosis, but these are pretty non-specific because all of the hallucinogens can cause something similar. Next, we have cannabis. Now, the things you want to remember about cannabis are all these ones. These are all for acute intoxication, where you have an increase in appetite, dry mouth, and conjunctival injections. Additionally, if there is prolonged cannabis use, patients might also develop social withdrawal. Finally, one thing that I do want to tell you is that excessive cannabis consumption below the age of 25 can lead to development of schizophrenia or psychosis, and that is called cannabis-induced psychosis. Now, based on these side effects, right, which are for intoxication, the withdrawal side effects would be, I'll say, opposite. That means you'll see a decrease in appetite, and in addition to this, you'll also see insomnia, restlessness, depression. Sorry, all of these non-specific signs. But a decrease in appetite is the most important one here. Next, you have MDMA and PCP. So for MDMA, right, which is ecstasy, it's usually a tablet and okay, yeah, actually the route of ingestion, right? Okay, we'll quickly go over all the other transporters that they affect and then the route of administration. So for MDMA, we'll see these non-specific signs such as euphoria, which is feeling very good, hallucinations, disinhibition, hyperactivity, thirst. But here, thirst is the most important one. That MDMA ecstasy can cause thirst. That is the most important side effect for MDMA. Now, because these patients have a lot of thirst, they're drinking a lot of volume. Sorry, they're drinking a lot of water. And now, because they're drinking a lot of water, you will see hyponatremia because of water leaching. And similar, water leaching is similar in mechanism to primary polydipsia or psychogenic polydipsia, where patients drink a lot of water and they lose a lot of electrolytes. Finally, know that MDMA can affect the serotonin receptors, and that's why these patients can also develop serotonin syndrome. Yeah, and hypothermia. Now, PCP or phenylcyclidine. PCP, usually they'll always give you someone who's very aggressive and has nystagmus. And I think psychomotor agitation is part of the violence. So anyone who is is very violent, who has a lot of aggression, and presents with nystagmus, you can think about PCP. That is what the USMLE will majorly ask you. And then, yeah, the side effects here for withdrawal, they're pretty non-specific for MDMA. Because you have depression, fatigue, change in appetite, difficulty concentration, and anxiety. Yeah. Finally, we come to alcohol. Now, there are 2 or 3 different outcomes when someone consumes a lot of alcohol and then they have withdrawal. Oh, sorry, they're talking about alcohol use disorder. Okay, so before we talk about withdrawal, I'll quickly tell you about alcohol use disorder. So alcohol use disorder, it's as the name says, these patients are drinking a lot of alcohol and they're consuming a lot of alcohol. Now, because they're consuming so much alcohol, usually they'll get problems with the liver, they'll get problems with the pancreas, they can get problems with the esophagus. Additionally, you can also develop problems with the kidneys. So multiple different organs which are being affected. The treatment for alcohol use disorder when patients cannot stop alcohol is you can give them naltrexone, acamprosate, And both of these medications, naltrexone and acamprosate, these will reduce the cravings. However, this medication, disulfiram, is a deterrent. That means disulfiram doesn't really reduce the cravings of the patient, but instead, what disulfiram does is give you a very bad hangover, which is that if the patient is on disulfiram and he consumes even one drink, then these patients will develop very bad hangovers, and that will push them away from drinking. Finally, it's always good that anyone who has any kind of use disorder, could be cocaine use disorder or stimulant use disorder, anything, it's always good for them to join a association or join a community where they can talk about freely and without judgment. Finally, we have Wernicke-Korsakoff syndrome. Now, we've done Wernicke-Korsakoff syndrome a lot of times, and we know that Wernicke syndrome or Wernicke's encephalopathy is a triad of these three symptoms, which is confusion, ophthalmoplegia, and ataxia. Remember that sometimes instead of ophthalmoplegia, they might also give you nystagmus. And finally, when patients develop confabulations after Wernicke syndrome, they have developed Korsakoff syndrome. Yeah. Here, I would say this part is the most important. Remember that before starting these patients on glucose, because they'll be severely malnourished, patients who have alcohol use disorder, before starting these patients on glucose, you always want to give them thiamine. And the reason why we give thiamine is because we want a very specific enzyme to start activating again. And that enzyme is transketolase, which is present in the RBCs, and it's a part of the glycolytic pathway. Yeah. So those are all the different intoxications. Now we'll quickly go over the receptors which are being affected, and then also the mode of ingestion. One thing I would like to point out here, though, is that for alcohol withdrawal, there's multiple different syndromes that you can develop. Initially, patients, when they're away from alcohol, they'll develop restlessness, they'll develop insomnia, they can develop tremors. However, after these symptoms, around like 12 to 24 hours, these patients might develop hallucinations. And usually these will be tactile hallucinations. Anything more than 2 days, though, 2 to 3 days later, if the patient hasn't consumed a drink in over 2 or 3 days, they will develop something called as delirium tremens. And now delirium tremens is when the patient has hallucinations, patient is very aggressive, patient has some kind of psychosis, that's possible, hallucinations. Patient will also, it's possible that the patient also has some kind of seizure. So it's a very severe form of withdrawal. And the treatment for all of these alcohol withdrawals is long-acting benzodiazepines. Okay. So alcohol, usually it's consumed as a liquid. So people drink alcohol. And this works on the GABA receptors and then also on the NDMA receptors. I would say here, remember the GABA receptors more than the NDMA receptors because the GABA receptors are important. Both barbiturates and benzodiazepines, these are both medications or tablets which you can orally consume, and both of these work on the GABA receptors too. Opioids are used as an injection, usually on the arm, and they'll work on the opioid receptors. Inhalants are usually, as I said, so they'll usually what these patients will do is they'll grab a plastic bag, they'll put the inhalant in the plastic bag and sniff it. So that's how they'll get redness in the nose and also around the mouth. And that remember that inhalant is because of increased GABA signaling. Next, we have the stimulants. Now, will, methamphetamine will be consumed as inhalation. It's not even inhalation, but more of like an injection, I would say. amphetamines more as an injection. And the only thing you need to remember, you can remember all of these different transporters if you want, but remember that it increases neurotransmitter release. And then all of these are molecules which can increase neurotransmitter release. And these are for different molecules. So SERT is for serotonin, NET is for norepinephrine, VMAT is again for norepinephrine, DAT I believe is for dopamine. Okay. Caffeine present in coffee and tea, so we drink it. And this is actually an adenosine receptor antagonist. Now, this is very important to remember because sometimes the USMLE will give you a caffeine question and tell you that the mechanism of action for caffeine is adenosine receptor antagonist, and they might ask you which asthma medication can also block the adenosine receptor. So, what do you guys think? Which asthma medication can block the adenosine receptor?
Hmm. Which asthma
Yes,
medication?
not currently used.
Hmm. Ipratropium?
No, it's actually theophylline.
Oh, okay. Okay.
So remember that theophylline is also a adenosine receptor antagonist. Next we have cocaine. Now the way cocaine works, right, is that it again similar to amphetamines, which increase the neurotransmitter release. Cocaine will prevent the reuptake of these neurotransmitters. So all these neurotransmitters, norepinephrine, serotonin, dopamine, it prevents the reuptake of these neurotransmitters. And one thing with the cocaine intoxication that I would tell you, right, is these patients, you do not give them beta blockers. You do not want to give beta blockers to anyone who has cocaine intoxication because that increases the risk of them dying. And it's like an absolute contraindication. Cocaine will be consumed by snorting through the nose. And then we have nicotine, usually in cigarettes, so inhalation or, yeah, inhalation. And nicotine, it activates the nicotinic receptors and across the entire body. Next, we have these hallucinogens. So LSD is a paper tablet which is sublingually consumed. And the way it works is it works on the 5-HT2A receptor. Now, do you guys remember which other medication can work on the 5-HT2A receptor?
Serotonin?
Yeah, so 5-HT2A is the serotonin receptor.
Yeah.
That is correct. So 5-HT2A is a serotonin receptor, so it will majorly work on the serotonin receptors. Yep. And then we have cannabis. Now, cannabis actually works on cannabinoid receptors, and there's multiple different types. Here they write CB1, which is cannabinoid receptor 1, but it can actually work on a full range of receptors. And it's usually also consumed by inhalation. So, like, yeah, you smoke it. Next, we have MDMA and PCP. Both of these are medications, usually tablets. And then remember that MDMA works similar to methamphetamines, where it increases the neurotransmitter release. However, for PCP, this is a very unique receptor action, which is it works as an NDMA receptor antagonist. So this here is the most important thing to remember, along with the violence and nystagmus. Yeah. So, guys, any questions with these medications? like the intoxications and the withdrawals.
All good.
Perfect. I know, I've quickly told you all the important things in these withdrawals and intoxications. And when we discuss these questions, hopefully we can get in more detail, or like we can go in more depth as to how the questions would be presented.